free to enter any questions you may have throughout the presentation. Note that the Q&A is not available for all versions of Teams. Please avoid using the chat box to submit your questions. It helps us to monitor them more effectively when they're all submitted in the Q&A icon. If you do submit any questions in the chats, I'll be there to move them into the Q&A icon, so don't stress. We'll make sure that your questions hopefully get answered at the end. We do our best to have all your questions answered during the Q&A session at the end of the presentation. To protect your privacy when you ask a question, please do not use your name or provide any other personal identifying information. We will collect those questions at the end of the presentation and address as many as we can. We also invite you to send any further questions to ontario.programs@kidney.ca. If you are having any difficulties with joining or viewing the webinar, please email RIT support at Stephen.Bitaxi, Bitaxi, @kidney.ca. The information presented in this webinar is current as of Thursday, November the 30th, 2023. Please remember that the Kidney Foundation does not offer medical advice. For specific information about your own situation, please speak with your healthcare team. This information is intended for an Ontario-based audience. Now I'd like to welcome our amazing moderator, Dr. Christine Ribic.
Hello, everybody. I'm really excited to be here today. Thank you so much, Sadia, for setting us up here. This is going to be an excellent opportunity for all of us to connect. My name is Christine Ribic. I'm a renal transplant physician, and I also function as a provincial medical lead for kidney transplant at TGLN Ontario Health. I'm joined here by my wonderful colleagues and also patient partners, who I want to thank each and every one of you for taking time out of your busy schedule to come to this important event. I think your ongoing dedication and coming to the events and planning them really speaks to how passionate you are about ensuring that we all have a wonderful forum to discuss important topics like life after losing a kidney transplant. So you may recall the first webinar that we had in this series. We had a really great opportunity to hear from one of our patient partners and hear her journey and the emotional, physical, and really kind of some of the turmoil and also hope that is that what people find themselves in the process of losing their kidney transplant, not only from the patient perspective, but we also heard this from our healthcare practitioners, who are also equally invested and really do have like an emotional tie to the journey that patients are on, as we're on the journey together. And so today is going to be another opportunity where we can kind of expand on this more. And I really would like to get started now and welcome our first speaker, who is Richard Dubois, who is a patient partner. He's going to speak to us about his current kidney transplant journey and how he's currently in the process. Really, his kidney function is declining. And really, he's going to talk to us about his next steps and what this has all been like for him during this particularly important time in his kidney transplant journey. Thank you so much, Richard, for being here.
Thank you, Dr. Ribic, and hello, everyone. I'm Richard. It's a pleasure to speak with you all today and share my kidney journey with everyone. I'd like to start with sharing a little bit about my past, a quick recap, as it were, of my kidney journey. I was born with a kidney disease called Alport syndrome. Alport syndrome is a kind of a rare one. And I was first diagnosed when I was about 5 or 6 years old. And the reason why I was able to get such an early diagnosis is because with my particular kidney disease, there are other things that can happen to you physically, such as hearing loss and vision problems and swallowing problems with the digestive system. So because of that, my parents immediately thought, no, there's something wrong with me. And so my doctors fairly quickly figured out that I did indeed have kidney disease. So for me, living with kidney disease has been a lifelong journey. I've been a kidney patient for over 50 years now. And during those 50 years, I've sort of had the opportunity to experience a little bit of everything from dialysis, different types of dialysis, home dialysis on peritoneal, and also hemodialysis in the hospital. I've had 2 transplants. I'm currently enjoying my second transplant, which, as Dr. Ribbit mentioned, isn't doing so well. And but previously, my brother gave me a kidney, so I've had a living donor in the past, and my second transplant was from a deceased donor. I've also had a number of other chapters in my kidney journey, and I won't go into too much detail with that. But needless to say, because of kidney disease, it's an experience that's very systemic. I think with anybody who is a kidney patient, you experience a lot of side effects. You experience a lot of life interruptions with school or career, and so many other things happen. And just like everybody else, my journey has been unique and ongoing. So, and one of the things I wanted to share today in particular is that while our last patient speaker from the last webinar had a really wonderful journey to share with everyone about her past, I wanted to focus a little bit more on my present because, as it were, here we are in a webinar discussing the loss of a transplant or the loss of kidney function, and I happen to be going through that experience as we speak. So I was jokingly mentioning to people how, well, this is kind of like a live stream of losing your transplant. And this is a situation where my wife and I were talking about this, and I said, well, I should feel more strange about this, or this should be more of an unpleasant sensation, or I should be losing sleep. But I'm not, because as with so much else in my life as a kidney patient, it's just another chapter. It's a big chapter. It's a noteworthy one, but it's not exactly the worst or most unexpected chapter in my life. And I've been through a transplant rejection before. So the process of getting a new kidney from a living donor is one that I haven't had to do for over 25 years. The last time, of course, being with my brother. So currently, very recently, in fact, my wife and I, my wife Kim she said long ago that she wanted to give me a kidney if ever anything happened, and lo and behold, something has happened. So Kim and I have only very recently started the process. We're officially in the system with the Living Donor Program here at the Ottawa Hospital. And one of the first things we've had to do is go through all of the paperwork, which has been submitted. And following that, there'll be a whole bunch of medical appointments, meetings, more paperwork. I have visits to the hospital that are planned up until next April. And all of this is very interesting, not panic-inducing, but I think that anyone who would feel upset at this process, that would be the most normal reaction I could think of. The details as they happen, it's a journey of discovery, and it can be very scary depending on the person. And so what I was hoping to do is, moving forward, is to sort of not exactly live stream, but post as things happen about what stages we go through, what the process will be like, what each project, give a description for people who are curious to learn more about the process of receiving a living donor kidney, and posting it online for people to check in. I'm happy to entertain any questions or any suggestions about how to proceed with that later on during our Q&A after our presentations. But for the most part, I would just like to share my experience with everyone, because I think it's an experience, it's arguably a one-in-a-lifetime experience to be able to share all of this with everyone, particularly while it's still going on. So we'll see how the story unfolds from there. So my philosophy about all of this is fairly straightforward, but I have a feeling mine is not unique, but mine is rather less usual because I've been a kidney patient for such a long time, over 50 years. I think that my calmness can come across as a bit of a sort of a facade, because I'm not always calm about it. It's worrisome, and I'm experiencing symptoms now. As of today, actually, I've decided I'm going to stop going to the gym, and I'm going to be doing exercises at home from now on. And as of this week, I've decided I'm going to just work at the computer when I do work, and otherwise keep things to a minimum. I notice I'm very tired. I get sore legs when I climb the stairs now. I'm experiencing edema, which is a swelling in the ankles, which is making it harder to put my boots on conveniently now that it's winter. All of these things are typical of kidney problems. However, and all of these things are familiar to me, but even so, they're worrisome, and they make you sort of think long and hard about how things are going to happen in the new year and what will happen next. And also how things are going to work out with my living donor, because even though Kim has very wonderfully and generously offered to give me a kidney, it may not work out. I may not be a good candidate to receive a kidney right now. She may not be a good match. The medical details our nephrologist can explain in better detail, but we don't know what's going to happen. Maybe I will be back on dialysis in the new year. It's a journey that is both exciting and frightening, and I would be really happy to share it with everyone, possibly in a Facebook group. So we'll see how that works out in the coming weeks. But in the meantime, I would like to hand it back to Dr. Ribbett and say thank you for listening in, and I'm more than happy to entertain all the questions you may have later on in our webinar. So thank you very much.
Thank you so much, Richard, for sharing such a personal story. And I know that it probably resonates with many on the call, and it certainly teaches us a lot about what you're going through, and your hopes and aspirations, and also some of your concerns. So thank you. I'd like to now pass it over to our next speaker, Marilyn Morey, who is a dietitian who's going to be speaking to us today. Thank you, Marilyn.
Hi, thank you so much, Dr. Ribbett. It's difficult to follow after Richard, but that was a fantastic presentation, Richard. Thank you so much. So good afternoon, everyone. Welcome to part 2 of Life After Losing a Kidney Transplant. So once again, my name is Marilyn, and I'm a registered dietitian. I put together this presentation, and I really hope I've included information that will help you and to help you to stay healthy. Before I start, I would like to remind everybody that I will not be giving out personal information in your unique case. If you do have any questions, I would recommend that you take them back to your nephrologist or your dietitian, and they'd be happy to answer your questions. So with that, so today I'll talk about the new nutrition recommendations for CKD and end-stage kidney disease. Then I'll discuss a little bit more in detail the importance of sodium, salt, protein, phosphorus, potassium, fluid, and calories. So some of you may have received a kidney transplant before, and before you needed dialysis, or you may have waited on dialysis for many years before you received a transplant, or like Richard, both. And you were told about the importance of keeping a healthy weight, exercising regularly, depending on what your recommendations are, and have a healthy, balanced diet to help manage high blood pressure, high blood sugar, excess weight gain, and promote overall wellness and health. You may have been told to follow a diet low in salt and high in fiber, or you're told to have a balanced diet, including lots of fresh fruit and vegetables, lean meats, reduced fat dairy products, whole grains, and plenty of water. At first, you may have been overwhelmed with all this information, and now you are told that your diet may change again. It's best to work closely with your healthcare team and accept their assistance to help you make the small changes that will have the biggest impact on your health and well-being. So remember, your team is there to support you. So, oops. Okay. Some of the other topics that you were advised to follow were to maintain food safety, but really and truly, food safety is everybody's issue. So this is something that I would ask that you continue to monitor how you handle your food, making sure you wash everything before you prepare it, separate your meats from your vegetables, cook it well, and making sure that you do not keep it at an unsafe temperature, and make sure to refrigerate any of your leftovers. So this picture here sort of summarizes some of the diet changes that you may expect. If you were doing well with your kidney initially, you would have followed the general healthy guidelines for all Canadians, such as Canada's Food Guide. However, when your kidneys begin to, or the kidney function begins to decline, you'll see further on the right-hand side where it says intake in CKD. These are some of the guidelines that we as dietitians try to promote to maintain or prolong your kidney function as long as we possibly can. In doing so, trying to delay the progression. However, if you do progress to dialysis of some sort, the diet will be different yet again. So be prepared and just, again, accept the support from your dietitian and your healthcare team. So let's look at these diet recommendations and compare the two. So let's start with the protein. You'll see for the general population, it's 0.8 grams. Actually, the numbers don't really matter, but you can see 0.8 for a healthy population, general average Canadian, and with CKD, we have a reduced protein recommendation. So the reason we do that is because we know that as we consume protein, the breakdown of the protein foods will produce waste products, and those waste products are what the kidneys are filtering. So if we can reduce the waste product that is being placed upon the kidney, we can certainly reduce some of the side effects that can occur from those waste products accumulating. So in general, we do recommend lowering the amount of animal protein, but not necessarily suggesting that everybody become vegetarian. And I'll talk a little bit more about that in later slides. So the other one, of course, is less sodium, which I'm sure you've been hearing throughout from the moment you were told you had kidney problems, or even before that, for other chronic diseases such as diabetes, high blood pressure in particular, and any heart problems you may have. So the idea behind a sodium restriction is because too much salt can cause you to retain fluid. And over time, you will see things like, as Richard had said, even the swelling of the feet or edema. But more concerning is the long-term effects, so how it can negatively affect your kidney function if you're in CKD, but it can also lead to high blood pressure, which, if uncontrolled, could lead to other complications such as stroke or heart disease. So this here is a nice little summary of what I like to consider a healthy diet for kidney disease. So basically what we like to recommend is, if you look at the first thing, is low sodium foods yet again, and eating a well-balanced diet of fruit, vegetables, whole grains, legumes, and lean protein. Now that comment, I'm going to get into a little bit more, but that one might surprise you a little bit because there were changes to the nutrition guidelines as of 2020. So in the past, we would maybe restrict some fruit and vegetables, and in other ways, we would just make sure you're not getting a lot of whole grains, again, for potassium and phosphorus, but we'll talk again a little bit more about that later on. So how do we make those determinations? We often look at you. We look at your blood test, and we look at the medications that you're on to decide how much or how little of potassium foods or how much of the overall diet we can adjust to make sure that you stay healthy. So once again, if you have any questions specifically about your situation, please go back and speak with your dietitian to talk about an individualized diet plan. Now, as I mentioned to you, as the diet will change depending on the stage or if you're on dialysis. So once again, I just want to emphasize, if you're not yet on dialysis, you may be told to have a low protein diet, but when you're on, you'll be told to be on a low protein diet, but do not eliminate it completely, because we don't want you to run the risk of becoming malnourished. However, once you start dialysis, we typically encourage you to have more protein to replete, to put back any of the protein that you've lost during the dialysis treatment. And again, it's to make sure that you're getting or absorbing enough of the protein without it being taken out from the dialysis treatment. So this is just another picture. I really like this because the emphasis here that I really want you to notice is that half the plate is vegetables. So is this what your plate looks like? I most certainly hope so. And if not, let's work towards that. So think about it. I really want you to start thinking about how maybe in the past you're thinking, wait a minute, that's not what kind of a diet I was told to before. So again, being open to change because the guidelines have changed and we are more able now to allow you to have some of the foods that in the past we would have said, absolutely not, you can't have that. So, work with your dietitian, incorporate some of the foods that used to be called like the absolute avoids. They may be incorporated back into your diet. So I hope that's good news for some of you that have gone through the very, very restrictive diet being on hemodialysis. So we really do hope that you can speak with your dietitian and really, truly always remember, we are not the food cop. We don't really want to make your life miserable. We are trying to help, and we do want to make your food as yummy as possible and not something to dread. So I wanted to just show you this because this is Canada's food guide. And one of the things I wanted to point out is how Canada's food guide is aligned with a lot of the other chronic disease diets, such as diets for high blood pressure, diet for high cholesterol, even the diet for diabetes. Very similar format. And once again, half the plate is vegetables, quarter of the plate is lean proteins. And you'll see there, they've also incorporated plant proteins, and the other quarter of carbohydrates is coming from whole grain foods. And they also suggest that we drink water instead of juice or pop. So the other parts of Health Canada that I think is really important to note is that they encourage you to take your time, kind of like the smell the roses kind of thing, right? It's stop and smell the roses. But it's important to sort of enjoy your food. Don't stuff yourself really fast. It's a matter of being calm and happy and enjoying your food, trying to involve other people. So make it a social event and incorporate some of those cultural foods that you've always enjoyed. Make it kind of like an annual event, make it as often as you can. Eating with other people is very, very positive, and it can make you feel good. It makes the food taste better too, I find. And here again, the encouraging of eating more fruits and vegetables, choosing healthy fats instead of, and avoiding saturated fats and trans fats, avoiding processed foods, having more water, use food labels, and being aware of some of the marketing ploys that people, food manufacturers use to get you to buy their food when they say it's healthy and it may not be. So let's take a look at sodium. Some of the more common sources of sodium are coming from the ultra-processed foods. So you can take a look at that, mostly from the baked foods, commercially baked foods. Mixed dishes, so things that you would find in either frozen or prepared meals, processed meats like deli meat, sausages, bacon, and certain cheeses. Some soups, some of the cream soups, actually most of the soups contain quite a bit of salt, and on it goes. Again, this is from, I believe it was from Health Canada. So what to look for, also then to note the things that they say on labels. This goes back to knowing what they're trying to say, try to focus on the terms like low sodium, very low sodium, or sodium free or no salt added, because when you look at lightened sodium or reduced sodium, you'll see that the reduction is there. But if the original product had a lot of sodium and they're cutting it in half and it's still a lot, it's still a lot. So just something to be aware of when you're reading the labels on sodium. What we do recommend is using more herbs and spices when you're cooking to help flavor the food, or you can use these prepared spice blends like Mrs. Dash or Clubhouse. but try, this is, okay, I'm not going to say avoid, but certainly have a discussion with your nephrologist or dietitian if you're interested or considering using these so-called salt-free substitutes. Now, these ones are a little bit different than the Mrs. Dash and Clubhouse. These are actually made with something called potassium chloride. So you know how salt is sodium chloride? They're using potassium chloride. So if you need to be on a potassium limited diet, this might not be the right thing for you. So once again, it is something to have a discussion about. So here we go, about protein. So the first thing that you need to do when you're thinking about eating protein is the type and the amount. So it depends on what stage of kidney disease you're in currently. So if your kidneys were good at transplant, you're probably eating everything and everything was going well, and now you're being told perhaps to reduce. So again, the guidelines are promoting more plant-based proteins. It is not necessary to become vegetarian, but we certainly would suggest that you start to add some vegetable proteins into your food. So if you like to add some maybe kidney beans, lentils, chickpeas into your soups and stews as a start, then cutting back a little bit on your animal protein, that would be a really good suggestion. So what are some of the plant-based protein sources? So these would be some of the things that we would be recommending now, as opposed to what we did in the past. So again, please be open to these changes. I hope you are. We're adding food back into our recommendations. So some of the things, as I mentioned before, certain beans, certain peas, certain lentils, nuts, quinoa, tofu, plant-based milks, and whole grain breads and cereals. Oops. So let's talk about phosphorus. So I just put these down. So I'm not going to go into phosphorus foods specifically, but I want to focus on these ones because these are foods that are high in phosphate additives. So that's just something I want you to park in your brain as I go on. So why is it important to know about phosphorus or to eat less phosphate additives? Well, phosphorus is really an important mineral to have in your body, and it does do a lot of important things in your body. However, too much can cause problems. So why do we want you to eat less phosphorus? It's to help protect your bones and your blood vessels. So basically what happens if you have CKD, phosphorus can build up in your blood. Too much phosphorus in your blood pulls the calcium from your bones, making your bones thin and weak and more likely to break. High levels of phosphorus in your blood can also cause itchy skin and bone and joint pain. So again, focusing on the phosphate additives, which I'll talk about a little bit later on, or your healthcare provider may talk to you about a phosphate binder with meals to lower your amount of phosphorus in your blood. And it's a binder, it's a medication that you take with your food. It binds onto the phosphorus and it doesn't allow it to get absorbed into your blood and is eliminated in your stool. So again, these are just some of the more common sources of foods with high phosphate additives. So again, basically ultra processed foods. So these are the foods that are like frozen convenience foods, packaged foods, and things like that. It also includes things like takeout and restaurant foods because very often they use similar products in their foods. So what are we looking for when we talk about phosphate additives? Here's some of the lists. You're looking for the letters PHOS within the word. So if you look at dicalcium phosphate, hexametaphosphate, monocalcium phosphate, phosphoric acid, et cetera. And if you look at Kraft Dinner, it actually has 3 phosphate additives in there. So this is some of the things that I would like you to start, considering to look at. So then we'll talk a bit about potassium. So most people know about potassium if they've had any sort of education with a dietitian regarding their CKD. So why would we recommend probably making sure that we have the right amount of potassium? Well, it's to help your nerves and muscles work the right way. Potassium can occur, problems can occur when your potassium levels are too high or too low. So if you are taking certain medications, your potassium levels could go up or go down as well. So it's really important that you speak with your team to know what the number is and listen to the dietitian's recommendations to either increase or decrease what your needs are. So again, remembering salt substitutes are high in sodium, high in potassium. It's something you can talk to your dietitian about if you can or cannot use them if you want to. And certainly one of the things that we try to prevent is a condition called hyperkalemia, which is high blood potassium levels. And the concern is that it can certainly cause problems with your muscle and nerves, and particularly your heart. So I will go on. So basically, I wanted to show you this. It's an example where, you know, if we're focusing on low sodium too much, let's see here. So this original V8 has 640 milligrams of sodium, and the low sodium has 140. Great, right? But if we look at, if we look at the amount of potassium down here, the original has 470, but the low sodium has 850 milligrams of potassium in 1 cup. So just something to keep aware of. This is how much potassium can be increased in a product if they use potassium chloride. So fluid intake may or may not be important. It's something that, once again, to just be aware of the sources of fluid from your diet. It's not simply just water and juice, coffee, tea. There are other things that are maybe solid. We also include things like Jello and so just knowing where the fluid is coming from in the case you require a fluid restriction. So here again, not everybody does. Some people may, but you should definitely be aware of where the fluid is coming from. So, and lastly, I just want to touch on calories. Of course, you know the calories from the nutrition facts labels. It's there, it's very obvious. Sometimes what we do with that is, if you are trying to lose weight, try to reduce your calorie count, certainly check different food products and try to pick the lower caloric. So if you need to gain weight, your dietitian can give you tips on how you can safely increase your calories to gain weight. So that's it for me. I hope I was able to touch on at least some of the important points to keep you healthy. And that's my dog, Harley. So thank you very much for your time and attention.
Thank you so much, Marilyn. That was extremely helpful. You are not the food cop. You are our good cop that's navigating us to the right food. So thank you so much for doing that. I will now hand it over to Dr. Kim, who I'm very excited to hear speak. And he is multitasking. So not only is he here on this webinar, but he has completed, I think, 6 transplants this week. So he's very busy and walking the walk and talking the talk. So Dr. Kim, I'm very excited to hear you speak to us now.
Thank you, Dr. Ribic. Really appreciate it. Thanks everyone for joining. It's a real pleasure to be here. And at the same time, it is my sort of second time go around. And actually I had Dr. Ribic's role last time. And so it's quite nice to be one of the speakers this time. So I'm going to be talking about life after losing your kidney transplant, sort of some of the more medical issues that you may want to be aware of. But before I do that, I thought I'd sort of introduce myself a little bit. And so who am I? So my official titles, I'm a transplant nephrologist at the University Health Network, UHN. I'm the director of the kidney transplant program here. I'm also an associate professor of medicine at the University of Toronto, both at the Faculty of Medicine and at the Institute for Health Policy Management Evaluation. And I also have a significant research component as well. Sorry, I'm just gonna end the show here for just a second so that I can actually close my email because it keeps ringing. My apologies. Let me just go back again. There we go. All right. So as I mentioned, I have a significant research program as well, where I do population-based research with large data sets at the Institute for Clinical Biosciences, as well as in other sort of arenas. But most importantly, I'm a husband to my wife, Jennifer, who's a dentist, and I'm a father to 2 girls, Maddie and Hannah, who are, of course, the loves of my life. And just as a sort of a little tidbit, doctors are people too. And so we've got hobbies and do other things outside of medicine. And so I actually have been a practitioner of an art called Brazilian Jiu-Jitsu for a few years. I'm terrible at it, but I keep persisting, and I'm a blue belt, which is just above white belt. So I'm not quite a beginner, but a bit of a novice and intermediate. And I think probably the biggest thing to take away there is that or at least what it's taught me, is it's always a good idea to have something in your life that you're doing that you're not very good at, that you have to learn and struggle and get better at. I think because ultimately, especially with our jobs and so forth, we really get good at things, we get to know things, but it's really nice to be able to sort of struggle a little bit and help ourselves grow a little bit in that space. So that's what Brazilian Jiu-Jitsu does for me. Okay, so this is an outline of the presentation. So I'm going to be talking about general eligibility criteria, or eligibility as it relates to another kidney transplant if you've lost one already. Then I'll talk about the different kidney transplant options, of course, the two being living donation and kidney donor transplantation. And then in particular, I'm going to talk about a topic called immune compatibility and sensitization, which becomes possibly a little more important the second time around or the third time around, as Richard was talking about. And then from the provider's perspective, I'll just sort of give you sort of some high-level views that I've seen in terms of the emotional experience, or the journey that patients go through along with their families, and provide some insights there from my perspective. And then finally, just highlight a few areas of research that are ongoing that hopefully in the future will help patients live longer with their kidney transplants. So what about eligibility for another kidney transplant? Well, in a nutshell, it's basically the same as your first transplant. And so really it's about, your general health and ensuring that, for example, your heart is healthy, that you don't have any active infections, and sort of the rest of your blood tests, and the other organ functions are within normal range, or at least acceptable to undergo a surgical procedure, and then of course receive the medications you need to maintain the function of the kidney long term. One of the sort of special considerations the second time around or the third time around will be that you already may have still a kidney transplant in your body. For some people, that kidney transplant may be removed, or for many, actually, the kidney transplant doesn't cause any problems, and so we choose not to remove it because, again, it subjects you to another surgical procedure with its potential complications. So patients may still have their kidney. So as a result, the new transplant would have to go into the other side. If that's not possible, then sometimes our surgeons will actually remove the kidney that currently exists at the time the new transplant is placed. So that's a little bit more complicated, but that's a possibility. But these things will have to be sort of planned out in advance. So there are some surgical technical issues that need to be considered in the setting of a retransplant that, of course, you will discuss, and decisions will be made with the surgeon and your medical teams about that issue. Really important part of this process, of course, is the psychosocial health of yourself and your family and potential living donor if you have one, and so forth, and making sure those issues are addressed and thought of carefully, because you're going through this again, and you've undoubtedly been through a number of emotions through the whole process of losing that first kidney. And so questions might come up, or feelings might come up that are a bit uncomfortable or uncertain and so forth. So I think it's very important to make sure that we acknowledge and address these issues as well, because sometimes we can get so caught up in the medical aspect of things that we don't think about the importance of these issues as well. So your social worker and other sort of members of the team can provide sort of support in that regards. And there are some issues that may have arose during the first transplant that will also, inform how we do things the second time around. So I'm going to talk about this issue of sensitization in a subsequent slide. There are some kidney diseases that can recur in a kidney transplant. So for example, a kidney disease like IgA nephropathy or something called FSGS. So it doesn't invariably recur, but it can. And so if it does recur in the first transplant, then the chances of recurring in the second transplant are considerably higher. And so there needs to be a strategy around that. Sometimes, unfortunately, it could mean that being able to retransplant, at least at that time, is not appropriate until some new treatments or therapeutic approaches are available. But nevertheless, it's just a consideration that needs to be made in the context of that next transplant. Obviously, if you've had infections also, so for example, certain viral infections like something called BK virus, if you have infections during the first transplant, which may have actually negatively impacted on the function of that transplant, and again, not a contraindication necessarily to proceeding to the next transplant, but an important consideration around how we manage your immunosuppression and so forth on that second sort of go around. So making sure all those considerations are made. Also, if you were diagnosed with cancer during your first transplant and were fortunate enough to be treated and in remission, then going on to another transplant, of course, would then require further immunosuppression. And so how would that potentially impact on your risk of subsequent cancers? That has to be weighed in as well. very difficult to quantify frequently, but at least having the right people at the table with the appropriate consultants and so forth to weigh in that in your evaluation to make sure all the planning is done properly is really, really important. Okay, so moving on then to kidney transplant options, you've got living donation and and deceased donation. And so with a living donor kidney transplant, you know, one of the wonderful things about having a living donor available who may be willing to donate to you that second or third go around is that you may be able to plan to undergo a preemptive transplant. So before the need for dialysis, one can then sort of undertake the workup and their living donor can do the same. And if all goes well, the two converge at a certain point where a transplant can happen and hopefully avoid the need for dialysis. And that would be the ideal scenario, certainly. And in the repeat transplant setting, it might be even somewhat more facilitated by the fact that you're quite already connected with the transplant team in the care of your previous transplant. But those discussions would have to be had. And of course, one of the key factors to being able to do that is having a potential living donor available to you. Now, I'm going to talk about the sensitization issue after the slide, but there is this issue called sensitization where because you were exposed to a prior kidney transplant, your immune system may be more revved up or more sort of looking out for, say, for example, for another a different kidney to come into the body and potentially increase the risk of rejection. So in that context, you know, finding a compatible donor might be a little bit more challenging. But if you do find someone who's willing to donate to you, even if you're not directly compatible with them in that regards, having a living donor who's suitable to donate allows you then to enter a national program called the National Kidney Pair Donation Program, which is administered by Canadian Blood Services. And essentially, it's a kidney swap where you can actually say, for example, my donor can't donate to me, but that individual, the donor may be able to donate to another recipient who needs a kidney. And his or her donor might be able to donate to me or donate to someone else. And then the person at the end of that chain comes, the donor may be able to donate back to me. So these kidney chains or swaps can be done. And many of you, I'm sure, have heard of this. And it's been a huge success across the world, but very much so in Canada. And I think a big part of it is because the cohesion of our country in terms of the different programs and how we sort of work together. So that's been a very successful sort of venture. So having a living donor or a medically cleared donor who can donate has advantages beyond just preemptive transplantation and donation directly to oneself, but also expand opportunities for transplant as a result. Okay. And then moving on, then if a living donor, unfortunately, is not available, then a deceased donor kidney transplant can be pursued. And so typically there, one would have to go on a waiting list to wait for a kidney. And you know, people ask, of course, you know, how long do I have to wait? What are the main factors that determine that? And the main ones there are the regional donation rate and how frequently donor kidneys are coming through. Blood type is also a major factor as well. So the blood types like B and O tend to just wait a little longer than A and AB. A major determinant of where you sit on the list is how long you've been on dialysis. And so we actually have a little sort of allocation point system that incorporates how long you've been on dialysis as a major part of it. And then the issue of sensitization there, which keeps coming up, which I'll explain a little bit more in detail in the subsequent slide. And then there are these other sort of, once you put out, you're on a list, you may also qualify for what's called the extended criteria donor list. And that's a list where patients consent to receiving kidneys that are potentially a little older, may have other conditions that don't allow the kidney to last as long, for example, versus a very young kidney, but nevertheless can be quite suitable, especially for a potential older patient or with diabetes who might not do very well on dialysis. Being able to get that kidney sooner, even if it's not a perfect kidney, certainly will provide an opportunity to get off dialysis, enjoy a more productive life, live more healthy for quite a period of time. And some of these kidneys can last a long times, and they vary in terms of their quality as well, but nevertheless can, most importantly, will increase opportunities for transplant. Another sort of group of donors, deceased donors, or at least a category that we sort of specify, which actually is sort of a global category that can sort of subsume the other ones as well, something called exceptional distribution donors. And essentially it's a Health Canada sort of label, but ultimately these are donors that may have certain, you know, features that might put, for example, them at the donor at a higher risk of having acquired a certain infection in their lifetime, for example, HIV or hepatitis C or hepatitis B. I mean, these things are, of course, all tested before donation and ensured to be negative before proceeding. But nevertheless, those tests, although excellent, may have a small probability of being falsely negative. And so willingness to sort of say, you know what, that risk is worth taking because I really want a transplant, will potentially increase opportunities as well for a transplant. And by the way, in the past, hepatitis C, which is a liver virus, was the most common cause of liver failure in the world. And because there was no good treatment options, donors who had hepatitis C, we never used their kidneys, because invariably, if you use the kidney, you would transmit the hepatitis C to the recipient who didn't have hepatitis C in the first place. However, now there are curative treatments, and at UHN we use a treatment that you only need for 1 week around the time of the transplant that essentially cure and eliminate the hepatitis C. So now we have ways to actually continue to expand the donor pool with kidneys that we couldn't use previously. We're using now quite effectively with excellent results because of these innovations. And then finally, this system, as I talked about, there's a kidney pair donation system that helps to increase opportunities for a living donor transplantation. In the deceased donor transplant setting, sometimes the transplantation may not be as accessible because of this issue of what I call sensitization, which I'll go into more detail. And this is where a national sharing program of deceased donor kidneys can really help, because you have more options and more potential donors who could be compatible with you. And that's a system that's administered by Canadian Blood Services, like the kidney pair donation system called the Highly Sensitized Patient Registry. And so that will give you greater opportunities to match to donor kidneys that may be suitable to you or compatible with you. And as you can imagine, the larger the pool of potential kidneys in that regard, the more likely you will find a match. And so I've talked to sort of in circles a little bit about the sensitization issue. So I'm going to sort of highlight this a little bit more and sort of broaden it to the category of immune or this notion of immune compatibility. So what do I mean by immune compatibility? Well, there's two main considerations there. One is one's blood group. So if you are, for example, blood group O, essentially, which is one of the most common blood groups, that blood group means that you will tend to have what are called antibodies, or I like to sort of call them like the soldiers of your immune system, so to speak. You're born with antibodies against blood group A or tissues with A or B or AB or those sort of specific proteins on the cell surface of the cell. So therefore, one cannot readily sort of receive a sort of, for example, an organ from a blood group A donor, for example, if you are blood group O. However, if you're blood group AB, you're actually the universal recipient. You can actually receive an organ from pretty much anyone. So it turns out O donors are sort of universal donors, so to speak, or people with blood group O, while as people with blood group A are universal potential recipients. The reason why this is also important is because the way the sort of donors come through in general, there tends to be a bit of a greater mismatch between the recipients of blood group B and O who need kidneys versus donors who are blood group B and O for many reasons. Whereas blood group A and AB, the sort of availability of donors tends to be generally a little higher, so therefore the waiting times tend to be a little shorter. So therefore, an important consideration there as well. But that is one factor as it relates to immune compatibility, and so you have to have a compatible donor when it comes to blood group, okay? On the other side is this issue of what are called panel reactive antibodies, or those soldiers that I just talked to you about the immune system. They sort of go out into the body and survey your body for things that shouldn't be there, for example, bacteria and viruses. But it turns out actually what they do is they recognize a little signature on the surface of your cells that kind of distinguish you from someone else. And so it's kind of your own little signature, and you share some of that with your family members as well. And so if your immune system sees a signature that it doesn't recognize, these soldiers will go out and start to tag or start to sort of surround that particular cell, or in this case, a kidney. And then that sort of signals to the immune system, send out other soldiers and tanks and so forth to go out and destroy that thing because it shouldn't be there. And so actually that's what rejection turns out to be, right? Is that the immune system is doing its job, so to speak, to defend you against something that shouldn't be there. But obviously we don't want that to happen. So we need to convince it to leave it alone. But if you have high levels of these antibodies, unfortunately, it does increase the risk of you rejecting that kidney and rejecting it quite aggressively. And so now you might ask yourself, well, why would someone have these antibodies? So really, ultimately, it's any opportunity for your body to have been exposed to other people's tissues or blood and so forth. So, for example, a prior kidney transplant is a very strong stimulus for the development of these antibodies. Blood transfusions can also do that as well. And then actually for women, they unfortunately, there's another sort of source of what's called sensitization, which is pregnancy. At the time of particularly for vaginal delivery, you're going to have mixing of blood, and then therefore mom gets exposed to the child's father's HLA, and so as a result, they might develop these antibodies as well. So this is another consideration around the compatibility and finding an organ compatible with oneself, and that's why in the second or third go around, there may be a little bit more of a challenge finding that compatibility because of the prior exposure. Not impossible, but certainly a little bit more challenging and an important consideration moving forward. Okay. How about the emotional experience? Of course, patients, of course, would be able to speak to this much better than I. But I can say certainly in my experience with patients, there's a range of emotions. Typically, of course, with the loss of a kidney, generally, of course, on the negative side, and so the sense of loss or sadness or frank mourning actually can happen because it was losing a part of yourself, both literally and figuratively, that has been providing you, sustaining you and providing you some level of quality of life previous to the loss of that particular organ. As you can imagine, anger could be a part of the experience as well, because you wonder, why me? Why would this happen? I thought I did everything right. And I'm being subject to this terrible, kidney failure, and why would this happen to me? So totally understandable, and could be very frustrating at that. Of course, there could be regret or guilt. Maybe I could have done more. There's also potentially the guilt as it relates to, if you had a living donor who had given you that kidney. I promised to take good care of it, but look at me now, the kidney's starting to fail. So there are those emotions that can come into the mix as well. Of course, with the uncertainty of the future and one's health, fear and anxiety is inherent through this process. And so something that obviously requires people to sort of be able to acknowledge and express, but also discuss and seek support for. And then finally, of course, a sense of hopelessness that, I've already had a transplant. There's probably no hope for me now, or maybe this is the end of it. And so again, an important piece to sort of acknowledge, but also have a discussion with your healthcare team and your family, of course, around some of your next steps, the various options, and so forth. So an important spectrum of feelings. I'm sure there's many others as well, but these are the ones that I tend to see. And as Dr. Ribig mentioned, healthcare providers can also go through some of these emotions as well, especially around sort of the guilt and the feeling that we let patients down. And we certainly go through the feelings of sadness as well. So we share that emotional journey with you. So ending off the presentation, then, what are some areas of research that are ongoing right now that might increase the lifespan of a kidney transplant? So there are some new anti-rejection drugs, what are called biologics, that are on the horizon that potentially can sort of target the way the immune system may sort of go after the kidney. And so those are sort of have some promising potential applications in the kidney transplant world. There's also some novel treatments that could prevent certain infections that could lead to problems in the kidney transplant and your general health that may reduce the longevity of the kidney. So, for example, new treatments for certain viruses called cytomegalovirus. There's actually some new drugs that are being tested in clinical trials for what's called the BK virus, which is specific to the kidney. So quite exciting potential advances there. The other thing to keep in mind is that half of all kidney transplant failures occur not because the kidney itself failed, but unfortunately the rest of the patient failed, i.e. died, death. And so heart disease, cancer, two big killers in our transplant population. And so advances in heart disease, cancer prevention and treatment are really important, actually, also in the kidney transplant arena. Unfortunately, not many kidney transplant patients are studied directly in the application of these treatments, but I think Dr. Ribig would agree with me that we tend to try to apply these innovations liberally in our patient population as well, because heart disease and cancer is so important. And then finally, there's the evolving area of cellular therapies and cellular engineering and the potential for kidneys to be grown in a petri dish and potentially using our own sort of cells to do so, which would allow us to then be able to have these kidneys potentially without medications and allow it to last longer and so forth. So those prospects are still there, but I would say not ready for prime time for quite some time. And finally, there's a renewed interest in xenotransplantation, the idea of using organs from other animals like pigs as a new available source of organs. And not only will that expand the opportunity for transplant, but also with specific engineering could allow one to get away with less medication, for example, and potentially increase the longevity of the kidney as well. Okay, so to summarize then, eligibility for another kidney transplant is similar to the first transplant with a few special considerations. And so a discussion with your healthcare team is very important there. Retransplantation occurs through living donation, deceased donation, again, much like in the first time around. We talked about immune compatibility and sensitization and why that's important, both in the context of transplant as a whole, but particularly in terms of repeat transplant because of those prior exposures that we may have had. There's a range of emotions, not only patients, but of course their family members and providers can experience across the spectrum when a kidney transplant fails. And finally, there is ongoing research, hopefully, to extend the life and improve the quality of life of patients living with kidney transplants. And we hope many of these come to fruition in the not too distant future so people can benefit widely. Okay, so with that, I'll end, and thank you for your attention.
Thank you so much, Dr. Kim, for walking us through really the multidimensional aspects of losing a kidney, but then also providing us with the road forward and the next steps and what to consider and what we need to really look at closely for the next kidney transplant. That was really, really helpful. I am now going to turn it over to our final speaker, last but certainly not least, Dr. Vincent Key. He's always an energetic speaker, so I really look forward to him talking to us today. Dr. Key, the floor is yours. Please enlighten us.
Thank you, Dr. Rivik. Yeah, I just finished a coffee, so I do feel a little revved up right now. So hopefully my speech doesn't follow suit. So a very, very happy Thursday afternoon to everybody. And thanks for joining this wonderful series. I'm going to try and share my screen here. Here we are. Okay. So I'm going to set a little bit of context to my presentation today. Are my slides proceeding? Sorry, just wanted to verify.
Yep. They are.
Okay.
Yep.
Okay, thank you. So just want to set a little bit of context to my slides. In our first series, we kind of talked about patients who have transplants, and we realize now that the transplant is starting to deteriorate, and we're trying to manage both the physical, the clinical, and the emotional sides of having that happen, and trying to optimize the transplant health. Now in this part of the series, we know that that's happening, but now we're starting to see signs that we are coming to the end, and a need to consider the possibility of renal replacement therapy again, and that would be either dialysis or another transplant, as Dr. Kim was talking about. So my focus today will be kind of to look at what is my role as a general nephrologist now managing a transplanted patient whose kidney is actually coming to its end stage, and what the process looks like, and what we can do to help support you and your family or other healthcare supporters. Now, one of the probably the most difficult topics to bring up with our patients is when we do know that renal replacement therapy and dialysis is definitely in the near future. I know I can only imagine how difficult it is for patients and their family and caregivers to know that that's coming. But even as a provider, that's always one of the tough discussions that we have to have with our patients, to inform them that it is a likelihood. So as a transplant patient in our clinics, we do have that discussion with you as well. And usually that happens when your transplant function falls below 20 mils per minute, or now we have another risk number called the KFRE that tells us what your risk of dialysis is in the next year or two, or in the next year, 2 years or 5 years. And that number could be somewhere between 20 and 40% is when we kind of start talking about the need to consider dialysis or renal replacement therapy in the near future. What can be difficult for our transplant patients is this could be their second time. This is likely their second time or more for having this discussion. And given the complexity of this decision, it is definitely very important for this to be a multidisciplinary approach, just like it is for our non-transplanted patients going through the multi-care kidney clinic for their first time. One of our first discussions when we enter this part of the journey is figuring out the type of renal replacement therapy that our patients wish to pursue if and when the transplant ends up failing. And many of you know the different modalities, including in-center hemodialysis, home peritoneal dialysis, and of course now, as Dr. Kim had talked about, even repeat transplantation. The information provided during these discussions is very important because this is a very big decision, and we want to make sure that patients know what the implications are and what it's going to look like before they decide on the specific modality. And thanks to Marilyn, we now have a very detailed information on what diet may look like. But we do know that there are changes that may happen as our kidney function falls below a certain threshold. And that means we have less toxin elimination. And this may necessitate a need to implement food restrictions. And for some, this is a discussion that's probably happening again. Now, when you had a transplant initially and it was functioning very well, it was all about liberalization of your diet. And now you're hearing again that, well, we're going to need to start maybe cutting back on certain types of foods. And I can only imagine the stress that may be for our patients. And as that transplant continues to further deteriorate, we know that appetite can be affected as well too. And so some people may start feeling a loss of appetite again and not being able to eat, and we'll need to think about maybe meal supplementation or change to the diet to make it more palatable for our patients. And again, I support the clear importance of our renal dietitians in ensuring that our patients get the best dietary advice possible to keep them well and as healthy as possible during this phase. You'll also know that our pharmacists will be very important as well. Just like before transplant, once your function starts to deteriorate, there are potentially a lot of things that need to happen with your medications. And that could be as simple as dosing. Some medications will need to be stopped because they're not indicated anymore. As your kidney function goes down, there may be other complications now arising. And some of you know about the issues with phosphate, the issues with anemia, and the same things happen as your transplant function goes down, as we need to start looking at things like erythropoietin injections to help boost your blood production. We may need to start medicines to help control phosphate in your blood if you can't control with diet. And this could be in the form of calcium and some of our new medications as well. As a transplant patient, it's also going to be important that we look at your immune suppressive medicines. Many of you may be on triple therapy with prednisone, some form of tacrolimus, and maybe even a mycophenolate. And as the transplant function deteriorates, we may need to start holding back. And this would be a collaborative opportunity with our transplant experts like Dr. Kim and Dr. Ribic in deciding what would be the best option as we move forward. And so you can see our pharmacists will be also involved in your care to ensure that you get the maximum benefit from the various medications that you are on without having as many side effects. Being the second or more times hearing about the need for going to some form of renal replacement therapy, we have heard from our patients, and from even our own experience, the stress of having to go through this. And there's a lot of things that have to happen before dialysis or another or even transplant can happen in an effective way. And so in this circumstance, our social workers will also be playing a very big role to provide that support to you. We want to make sure you have your own personal supports available as you prepare for dialysis or a second transplant. There's definitely a roller coaster of emotions that can happen, and this can happen not just in our clinics, but at home, at work, and in the community. And so having this support available to you in the clinic will be very important. And also, many of you are probably still working, and there may be questions about, so what are the supports available for me if, say, I start feeling unwell and I can't work as much as I can now? What can I do to help myself? And again, our social workers can definitely lend a hand to help provide you that information. Now, as your nephrologist and your care team, we're not just there to watch your kidney progressively decline. One of our biggest goals is how can we keep that kidney function going for as long as possible, to delay your dialysis for as long as possible. So part of that is trying to optimize all the potential risk factors that are present in your health. So that could be keeping your blood pressure as well controlled as possible, controlling diabetes as well as possible. And as Dr. Kim spoke about in his talk, yes, there have been a lot of updates in the realm of heart disease, diabetes, and more specifically in kidney protection lately. And so there have been new medications that are now evidence-based and proven to help prolong the health of your kidney, and also but support the health of your heart as well. And so even though some of the data may not be as strong in the transplant realm, we are applying them similarly to people with transplants and without transplants as well. So it's important to talk to your doctor about these options as well, to try and keep your kidney going as well as possible. And as I mentioned earlier, as the kidney function starts to go down, there may be a need to redose or rearrange your transplant medications in the form of the immunosuppressives. And so this is where we collaborate with our transplant colleagues to optimize that part. We'll look at your hydration status. Some patients are on diuretics for specific reasons. And so we will be watching your volume to ensure that you're not overly hydrated and not too dehydrated. And that will be important to keep your kidney healthy as well. We'll look at things like lifestyle behaviors like smoking, alcohol, and exercise, which we want to keep as good as possible for you. And finally, anything we can do to keep your medications easier. We know that there are a lot of medications that patients inevitably require to kind of keep their transplant going. And so there's a lot of medications. And so if there's a way that we can make it a little more simple, we will look into those options, and that definitely will probably help with maintaining ease and compliance for our patients. Now, once we've decided on what we're going to do in terms of dialysis, if that is the path we have chosen, we will then start looking at timing for creating an access. And for those who have been on dialysis before their transplant, you know very well what this kind of looks like. So if you're interested in hemodialysis, we will be looking at referring you to a vascular surgeon to create a new fistula or a graft. In some circumstances, we may look at old fistulas and grafts to see if there's any salvageability. And then for those patients who are interested in peritoneal dialysis, then we'll keep that in mind in terms of when we will insert a PD catheter for preparation for dialysis as well. I won't talk too much about this one because Dr. Kim very clearly and elegantly talked about what may look like for someone who may be interested in a second or a third or more transplant. And again, the process is very similar. And as your doctor and your allied team at the Multi-Care Kidney Clinic, we will definitely help expedite and assist you with the workup, all the testing that's necessary, and we'll liaise with the transplant team to ensure that we have everything done to ensure the process is as smooth as possible. So over time, we will get to a point when we know that we're going to need to start dialysis for those who have chosen this as their next step. And now, I think one of the things we all wonder about too is, how do I feel when my transplant really starts to get to start to fail to the point where I may need dialysis? And everybody's different, and not everybody starts feeling unwell at the same time. And this is also true for patients who haven't had transplants. So it's an individual experience for sure. But for the most part, some of the symptoms are similar. You can imagine as your toxin removal gets lower and lower, you're going to start feeling unwell because your body is retaining a lot more toxins. This may manifest as a loss of your appetite. You may start feeling nauseated, just not as well as before. You're more tired all the time. You're wanting to sleep all the time. You're losing focus. You just don't feel like doing what you really want to do. And then some of the more serious things, maybe things like shortness of breath getting worse, you're a lot more swollen, and sometimes you get chest pains as well too. The experience of the end-stage transplant or the end-stage kidney syndrome is definitely very unique to each person, but for sure, we will definitely watch out for this together. And once this does happen, this is usually when we say, you know what, it's time to start dialysis. And this is why we do like to have our accesses ready beforehand, before this stage comes around, so that we don't have to rush and go through a very stressful process to get you started on dialysis. And this process is important because we do want your journey back to or into dialysis to be as smooth as possible, and not one that's rushed and overly stressful, because we know that this is already a very stressful period in your life and your health as well. And so anything we could do to minimize that will be important. So in conclusion, once we get to this stage in your kidney transplant journey, you will still be cared for by a team approach. We will focus on what you want and provide you with all the information and support needed to help you with your decisions. And we will also work with your transplant team as well to ensure that your treatment for your current transplant is as best possible. And if possible, if there's a future opportunity for another transplant, we'll definitely make sure that that is expedited as best possible, and that we help you get what you need to get done as soon as possible too. So with that, I'd like to conclude my talk, and we'll return it back to Dr. Ribic. Thank you for your attention.
Thank you so much, Dr. Key, for that very, very informative talk and walking us through the journey. I want to thank all of our speakers today, and I know that with all the information presented, there is probably a very nice opportunity now for discussion and questions. So I'd like to pass it over to Sandra, who's going to navigate our question and answer period and direct questions to the appropriate person. I do want to mention that I think Dr. Kim did have to step off because he is on transplant service today, but Dr. Key and myself and all of our speakers remain here to answer any questions you may have.
Thank you very much, Dr. Ribic. So our first question actually is for you, Dr. Ribic. Could you please expand a bit on new immunosuppressants for transplant patients, in particular ones that target specific antibodies?
So it's a great question. Most of our immunosuppressive medications that we use are really kind of homogeneous in their approach. So what does that mean? They don't have a direct activity against a particular HLA antibodies. We do have immunosuppressants that are like, monoclonal antibodies that will target particular cells in our body that will reduce HLA antibody production, but we don't actually have immunosuppressants that target a specific antibody. So if I had a previous transplant, and if my donor was typed as an A2 is an HLA protein that's expressed on the kidney surface, and I have now developed something called a donor-specific antibody, a DSA towards A2, the immunosuppressant drugs we use are going to reduce all antibodies, not just the A2, but all antibodies. Now, there is one caveat to that. There's something called plasma exchange. Some of you may have heard about this. If you're having acute rejection of your kidney, so not chronic rejection is something that happens with kidney transplant, and this is why kidney transplant is not forever. We know that typically, between 12 to 15 years for a living donor and 10 to 12 years for a deceased donor, plus or minus a time frame, is what we expect kidneys to last. And that's because there's always this element of something called chronic allograft nephropathy, or this chronic rejection that's causing scarring. But in the case of acute rejection, you have a transplant and all of a sudden your kidney function goes off, we can use something called plasma exchange. And that plasma exchange, there are columns available that target specific antibodies. So we could get a column that's going to target a specific antibody, which we may have found when we do testing, that is now formed against your donor. But in general, the immunosuppressants that we use are ubiquitous. They cover all antibodies, and they're not specific for a particular type. I hope that answers your question.
Thank you very much, Dr. Rebick. Marilyn, I have a question for you now. So the question is, with lowering kidney function, should a patient avoid red meat completely and focus on proteins from chicken, fish, and vegetables instead?
Again, working with your dietitian, they can help determine what would be best for you. Overall, that is the general recommendation that most renal dietitians would offer. We are trying to promote more plant-based proteins, as I mentioned, and getting away from the red meats, certainly. It doesn't mean you need to eliminate them completely. I'm one of the kinds of dietitians that will try to incorporate some of these foods that are kind of evil, if you will, and incorporate them into your into like special occasions or things like that, where you're not eating large amounts routinely, but to have them every now and again should not be a problem. But again, I would urge you to speak with your dietitian. Everybody's situation is unique, so speak to your healthcare team. Hope that helps.
Thank you. So we don't have a physiotherapist on the call today, so I put this question out to the group. This question is, the person would like to continue to exercise as they deal with their transplant failing. However, they're concerned about the production of the enzyme creatine kinase, further damaging their kidney. So they're asking, should they stop workouts?
I'll take this one because I get this question quite a bit. No, don't stop exercising. Absolutely don't stop exercising. I think exercise is great. It keeps your heart pumping, keeps the blood flowing. And with regards to the concern for CK, I think the main thing there is just keeping yourself well hydrated. Definitely don't let yourself dehydrate when you exercise. Drink your water as needed. But there's so many health benefits to exercising that to forego it because of that concern would be more detrimental to you overall. And in fact, I think it's even good for the kidney as well. We know that exercise is good for kidney health as well, keeping it well perfused. And yeah, so don't stop. 10 more burpees for you right now.
So I noticed that Sadia is also posting some very helpful information to people about options for at-home exercise that people can do virtually. I highly encourage people to take a look at the post she's putting up about the virtual exercise program, because it's a very good one. Okay, so another question here. So this one could go to you again, Dr. Key. Can a kidney patient, I'm assuming it's a patient who's transplanted, choose home peritoneal dialysis as their first treatment option, or do they need to start with hemodialysis again first?
Yeah, so I actually don't think I don't think having a kidney transplant is an absolute contraindication to peritoneal dialysis. The concern there is that every time you do undergo some sort of abdominal surgery, there's always that risk that you may develop some scarring in the abdomen, especially where the peritoneal dialysis fluid is required to function properly. And so sometimes if there is a lot of scarring, you do peritoneal dialysis, you may find that it may not work very well. Some of our centers will can do an assessment of the abdominal cavity beforehand to see if there is a lot of scarring, and that could be done either with CT scanning. Certain centers, when they insert peritoneal dialysis catheters, they do it with a special kind of camera tool, and they can actually see if there's a lot of scarring. And if it is done with a camera, sometimes they can even take down some of the scarring to allow for peritoneal dialysis to happen. But I guess the short answer is it's not an absolute contraindication, and some people are able to do peritoneal dialysis even after transplantation.
Great, thank you. Dr. Ribic, I have a question for you. I know you're not a transplant surgeon, but I think you'll be able to help us with this one. So the question is, how is a kidney removed from a living donor? Is the surgery invasive, or is there a laparoscopic procedure that can be used?
Great question. So the answer is yes, it can be done laparoscopically, which is excellent. The healing time is much less, and recovery is much shorter. There are instances, though, I should say, where the laparoscopic approach may not be for everybody, and it has to do with kind of the anatomy of the kidney and whether or not there's multiple arteries and how how deep the kidney is, in a sense, and this can all be assessed prior to transplant. So typically at our center and at many centers across Ontario and Canada, laparoscopic is kind of the first approach, but they'll always quote a risk of what the risk is to conversion to open. And so in some people, that risk is going to be very, very low. And in special circumstances, they might say, actually, it could be as high as 50%, where they may have to convert. But they do try to do laparoscopic, and so that the recovery time is quite short. It's not unusual for our donors to leave hospital in 2 days or 3 days after surgery and go home.
Okay. Thank you. So I also wrote down some questions while all of you are speaking, so I'm going to ask some of those now. Richard, my question is for you. I know that you said at the beginning of your story that you're in the midst of preparing for another transplant. Have you noticed any differences so far in the workup process this time as compared to your previous workup?
I would have to say, yes, I've noticed a lot of differences. However, there is a 30-year gap between these two processes. So that's probably the biggest part of the differences. But if I eliminated that factor, I think the biggest difference is that it's a more thorough workup. There seems to be more interviews for the recipient, but especially for the donor. There is a greater emphasis on medical imaging and making sure everything is in the right place. I think it's an earlier beginning. My first transplant, I received a kidney from my brother, and I don't remember us doing the workup for 6 months prior. It was more like maybe half as long. So it does seem to be a far more thorough process. In part, I guess, because we're able to check out more things. Maybe one of the physicians could tell us that, but So, and I'm not complaining. I like the thoroughness of it. I like that no diagnostic stone is being left unturned. So yeah, this is our winter's. This is how we're spending our winter into the spring. So
Very good. Very good. Thank you. And Marilyn, a question for you. Sometimes patients are followed in a diabetes clinic and they have a dietitian there, and maybe there's a dietitian in their family healthcare team. So why should a patient have to come and see another dietitian?
That's a great question. To be honest, I asked the same thing. I think perhaps it's because in the past, the diets for different chronic diseases differed. And with the CKD diet or the dialysis diet, it was so different that we took hold of that. Now, however, as I showed you in my presentation, a lot of the diet recommendations for these chronic diseases are now very much similar, very much overlapping. It would be worthwhile to have that conversation with one of your dietitians and say, do I need to see you? I don't think I need to see you. And I don't think that's a problem, as long as your dietitian has the training, the appropriate training for diabetes, high cholesterol, high blood pressure, the whole gamut. So that would be my recommendation, because diabetes is a very specialized area and renal is a very specialized area. Sometimes putting them together might be a little bit more challenging, but again, with more whole grains and all that, yeah, you could speak to one of your dietitians and ask them, because I know it's an extra appointment. I had that conversation a lot. So yeah, speak to your dietitian.
Thank you. And these next couple of questions can alternate perhaps between Dr. Ribic and Dr. Key. If a patient has had a fistula that was used before their transplant, and then after transplant, they decide to have it tied off, could that fistula be salvaged and used again when the transplant fails?
Yeah, usually after a ligation, it's pretty permanent. So I think usually we end up having to create a new one or consider a graft in that circumstance.
Okay, thank you. And Dr. Ribic, for you, if a transplant patient needs dialysis, will their creatinine be at a similar level when it's time for them to start dialysis that second time as it was when they originally started dialysis before their transplant?
Yeah, good question. So the answer is it depends, right? So it's, you know, we don't start dialysis for a particular creatinine number. We really start it when your EGFR, you know, generally is around 10 or less. Sometimes it could be a bit higher, and their symptoms. That's the key. So when someone is kind of feeling like, geez, you know, I'm not really eating, I'm feeling very fatigued. And you know, sometimes even your transplanted kidney, you could have some residual kidney function left. There could still be a little bit of kidney function left, but you just still are feeling quite crummy. And so your creatinine may be higher the second time, or lower the second time around, but yet you're still needing to start dialysis. So to be honest, we don't get very hung up on that because once you start dialysis, the dialysis is actually, you know, doing the renal function for you. And we don't follow the creatinine after that once you start dialysis. So.
Okay, thank you. And then another question. If somebody has had COVID after their transplant, is there any special considerations that have to be addressed if they want another transplant?
Yeah, great question. So if you've had COVID after transplant and even if your transplant is functioning, the first thing I want to mention, which isn't quite the question, but I just want to make sure that we all know this, is that we would actually treat you with remdesivir. You would have access to a medication that has been shown to reduce the severity of COVID and reduce hospitalization. But I think what your question is getting at is there something that we need to consider for the second transplant because we've had COVID? And the answer is no. So, having COVID would not preclude you from having another transplant. There is some research that's looking at whether or not COVID infection might stimulate antibodies, new antibodies, that could limit the amount of donors that you may have access to. But, in the cases where it does stimulate some antibodies, what has been found is that it's not always long lasting, meaning that some of those antibodies over time can actually go away. So overall, I would say that, there's nothing that would stop you from proceeding with a transplant if you had COVID after your first transplant. Nothing would stop you to go to the second one, just if that was the only issue.
That's good news. It's encouraging.
Yes.
So we've had a couple more questions come in. Why is prednisone used in Ontario but not used in Quebec for immunosuppression?
Yeah, so there is some information and research on prednisone-free transplantation. What I would go on to say is that it does depend on the matching between you and your donor. In general, the research that has been done show that people that have a transplant have less of a chance of rejection on prednisone. The risk of rejection off prednisone is higher. So this is why the majority of people need to remain on lifelong prednisone, even though it's a very low dose at 5 milligrams. There are some exceptions to this, and those exceptions would include people that, for example, may be perfectly matched to their donor, with for example, a sibling where they might be perfectly matched. Then we can look at prednisone-free kind of regimens. It's very hard to kind of right now in the current landscape to predict who would be safe on a prednisone-free regimen. So that's why the majority of people are on prednisone.
Okay, thank you. This is a question for Dr. Key, but I no longer see him on the screen. Dr. Key, are you still there? Okay, Dr. Ribic, I put this question to you then. Has there ever been an instance where a person has an access prepared for dialysis, but ended up receiving a transplant instead? How long do you wait before removing the access?
Excellent question. Yes, there has been an instance because it's a great question because it does happen. Sometimes, there's someone that hasn't even started dialysis and they preemptively get their fistula made, and lo and behold, they get a kidney offer, and then we proceed to transplant. So the good news is that if it's a temporary access, like a central line, once we know the kidney's functioning well, we could remove that at any time, actually, anytime. If it's a fistula and it's now matured or it's maturing, we're not in a rush to remove that because, I always tell people, sometimes people will say, I have a kidney transplant now. Can we get rid of this? And, it's like having collateral in the bank. If something is to go wrong, that's your safety deposit kind of area where, if you have to use it in the future, you have a way out to use it. So we really don't remove it unless there's an issue or if it's really something that's troubling you in other ways.
True. I recall 2 patients at different times who were actually coming into hospital to receive their perm cath insertion, start dialysis, and they are actually called those very days for transplant. So you just never know when those calls are going to come.
You never know.
Yeah. Okay, and we have one last question here. I'll put this one to you, Dr. Key. I know you talked a little bit about this during your presentation, but maybe you can just summarize this one more time for us. How do antibodies affect the ability to receive a donor kidney? How much would a previous transplant or blood transfusion make a difference? And is there a therapy available to counter it?
All right, so Dr. Ribic is going to evaluate me on my answer to this question because I do have to talk to my patients about this quite a bit. So we're talking about this issue about sensitization, which Dr. Kim talked about. So there are certain things that happen, I guess, in our lives, whether it be a transfusion, pregnancy, and even certain infections where our body is going to generate antibodies and then keep it in the memory pack. And depending on how many times we've had these events, we may carry a host of different antibodies that may one day become important because they may end up targeting a potential donor's kidney. And so when we do work up our patients for transplant, whether it be their first or second or more, there will be tests done to look at what type of antibodies you have. And these are in the form of, I guess, what they call PRA. Am I right, Dr. Ribic? Where we actually can screen your antibodies against a panel of different proteins to see if you actually mount an immune response to these proteins. And so the more you mount a response, the more antibodies you carry that may become an issue. But I guess the bottom line is there's no magical way to kind of tell how sensitized you are just from looking at your basic blood work or just hearing your story. Everybody's different. Some people are going to have a bigger immune response and create more antibodies. Others may not create any at all. But what will be important is that when we do start working you up for transplant is that you do the tests that the transplant center requires, and that's looking at your antibody panels, looking at any sort of donor antibodies that they may order. And these happen not just once, but they happen multiple times before your transplant happens to ensure that when the day comes for you to get your transplant, you're not carrying any of these antibodies, and so that the donor kidney is appropriate for you and matched properly for you, and the risk of any sort of rejection will be low. Did I pass, Dr. Ribic?
You got an A+, Dr. Key, as usual, A+. I would just add one tiny thing that's like not even, it's your A+ is still definitely an A+. The only thing I would add is that sometimes if we know, like, so let's say your kidney's failing, and then you come forward and you say, look, I have a living donor, and we figured out that you are a match to your living donor, and we think we're going to be able to transplant you very quickly and not spend a lot of time on dialysis in between. The one way we may be able to combat some new antibodies from forming is to keep you on a little bit of immunosuppression. And Dr. Key does that as well. We work together a lot of times with patients where we maybe maintain them on a little bit more immunosuppression rather than tapering it all off, just to prevent those antibodies from forming.
Very good. Another question has come through. What is the safest painkiller for transplant patients? I have been using Tylenol because it clears through the liver, but now I hear that this may cause liver failure.
Okay, I guess I can take this one. So Tylenol is safe as long as you don't have liver disease. That's the first thing I'm going to say. So it will only cause liver failure in two circumstances. If you already have liver disease that is diagnosed and significant, and you take Tylenol. And number two, if you exceed the maximal limit, which is actually 4 grams per day. So Tylenol is a safe alternative in kidney transplant patients. Just make sure you stay within the the constraints of the max dose, and we, when you go for your kidney transplant checkup with your blood work, we always check your liver function tests as well. That's part of the regular screening that's done.
Okay, thank you for your answers, everybody. It looks like we've come to the end of the questions through the Q&A. Sadia, are there any more, or Steve, that you can see that I have not reviewed?
I don't think so. I would ask if everyone could possibly give, their closing thoughts and closing remarks, and then we can end it off from there. So, Richard, why don't you go first?
Oh, I just wanted to say thanks very much to all the participants. I know that I'm part of the webinar, but I found that I learned a few things questions that I was going to ask my nephrology team in the coming weeks and months, and so some of you have really saved me some time on that. And as I mentioned earlier, I'm very happy to share what's going to happen next with me as I continue the workup for my living donor transplant with my wife Kim. So I'll try to keep the people posted on that. I'll keep the Kidney Foundation up to speed on that. And if one day we have a Facebook group going, I would encourage anyone to come check it out, and I'm happy to post there and answer questions there as well. So thanks, everyone. It's been great participating in today's webinar.
Thank you, Richard. Marilyn, you're on mute. We have you recorded.
I was just saying that I echo what Richard said, and I appreciate being here. I learn as well. I learn from hearing from other people, but I would urge you all to ask the questions you want to ask. Once again, as a dietitian, I find I'm asking the question, would you like this? How about this? How about this? And so I don't know what you want. So, or at least dietitians, we can't read your mind. It would be really important. We are here to help. We're not here to, berate you or anything. Please reach out, and we're more than happy to help you, keep it going, being healthy, eating the right foods. So that's all of my wishes.
Thank you, Marilyn. Vince. And you're on mute too.
I'm following Marilyn's approach. Well, I wanted to thank everybody too, and especially Richard for sharing your story with us. I think it's amazing having patient partners in webinars like this. I think the learning is more wholesome. We definitely get more everybody's perspective, which is important. And I guess I want to say this is definitely a very team journey, and we're definitely all here for you. We want to make sure your journey is as smooth as possible, and we'd like to be able to help make it that way for you. So again, like Marilyn said, you have questions, we're here to try and answer them, and we're going to try and make sure everything falls in place the way it should. And so thank you.
Great. Dr. Ribic.
Thanks, Sadia. I just wanted to thank everyone today, the speakers that joined and really imparted a lot of wisdom and hope to everyone on the call. This is not an easy time when you are coming to the end of your kidney transplant and looking to the future for hope and another transplant, or to perhaps transition to dialysis for a period of time. And let's be honest, in some cases, maybe to stay on dialysis or not pursue any of those options. So it's not an easy time. But I think what really resonated with me today is that you're not alone. There are many people on this call that are going through the exact same thing, and it's really comforting to know that there's a big group that can come together to share their experience and learn from each other, that you have immense support from your healthcare team and from Allied Health, and even from the Kidney Foundation Connect program with volunteers. And we know that this is, there's always new innovation coming. Dr. Kim touched upon new research that's up and coming. And we know that, as Richard very eloquently said, my workup is different. It's different, but my first one was 30 years ago. And so look how far we've come in 30 years. Aren't you excited to see where we're even going to be in the next 5 to 10 years? There's always new things coming. So thank you so much for allowing me to be part of this team. I don't know, Sadia, maybe Sandra, I don't know if you wanted to mention anything, because otherwise I would like to pass it back to Sadia. But Sandra, I want to give you a chance to say something as well.
Sure, thank you. No, my big thank you is to all the attendees today. Thank you for your wonderful questions. Sometimes people don't know what to ask because they just don't know. So by asking your questions today, absolutely, you have helped others. I want to thank the people that are behind the scenes that make this all run so smoothly and make us all look so good. So to Sadia and Stephen, thank you so much for for supporting us when we present. And then I know Dr. Kim is off the call, but that phenomenal news from UHN, 6 transplants, I am definitely going to be taking that back to my colleagues to inspire us and to build a little friendly competition with the other nephrologists I work with. That's just wonderful news. So thank you for that.
Thank you so much, Sandra. And thank you everyone for coming together for the second part and the new folks for joining us. And like Dr. Key said, we do become a family in every shape and form. And so I hope that going into the new year, we can start thinking of other amazing topics and have you guys come back to even, dive more deep into this. So great job. And I'm just going to share my screen real quickly to share a few more items that we have that are coming up. Bear with me one moment. Technology is always our best friend. All right. So we do have, so in case you did miss part 1 for this topic, it is on our YouTube channel, and that is at Kidney Canada. So please check that out when you do get a chance, and then you can watch part 2 when it goes up. Because again, information is power and knowledge is power. We also are having a few new support groups that are coming out in 2024. So we're really excited about this, and we're working really hard with our partners to make this happen just for you guys. So the first one is on reproductive care and chronic kidney disease. So for those looking to start a family, looking to learn about how to freeze their eggs, or so many different topics when it comes to this reproductive care. That is going to be coming out in January, and the first group, as you can see, is Wednesday, January the 10th from 7 to 8:30. The next one is we are holding a PKD, polycystic kidney disease virtual support group as well, working closely with the PKD Foundation in order to make this happen to support that population, because it is a large population and we want to make sure you guys have a space to chat about what's going on. And then lastly, our Chinese renal support group is starting back up. They're going to be hosting it every other month, and the first one will start on January 17th. So please look out for that as well if you're from that population. And then you guys did mention it, the Active Living Program for Life. I don't have the updated slide, I'm sorry, but that starts in January and flyers are with us. So if you are interested, let us know. We'll send them out to you, and we'll make sure to send them out to all the renal professionals on the call today. So you have it. It's free. It's by a registered kinesiologist, and it's just for renal patients with you sitting down and standing up. So definitely check that out at your convenience. And then lastly, all of these amazing folks on the call today mentioned peer support. And the Kidney Foundation is one of the best organizations out there that hosts amazing peer support, like volunteers such as Richard, where you can hear from their firsthand lived experience of what they've gone through, and then supported by the renal professionals. So connect with us today. You can do one-to-one or join a support group. We cater to whatever is convenient for you and your journey. Because like Richard said, everyone's journey is unique and different, and every patient, every living donor, every caregiver is unique and different as well at the same time. So for additional information, check out our website. And with that, again, thank you, Stephen, for all your hard work. We greatly appreciate it. Have a great and safe holiday, and we'll see you in the new year. So thank you very much, everyone. Bye.